Good evening, everyone, and welcome to this webinar on abdominal ultrasound, a tool for the internal medicine specialist. I have the pleasure to share this event, and my name is Helge Gilja. I am professor at University of Bergen. I'm also senior consultant at Haukeland University Hospital in Bergen, Norway. And I'm also director of the National Center of Ultrasound and Gastroenterology. So it's really a great pleasure today to be able to convey to you these 3 lectures, which I believe is highly clinical significant and will give you a lot of good tools for your patients back home. We are going to take a walk.
Landscape is a wonderful arena also to use ultrasound. We can use it both for the stomach, for the small and large intestine. And although there are some air and some contractility around, we can still get very nice images.
And also we take a walk in this fantastic landscape, looking at the kidneys. We will look at the liver and upper abdominal pain. However, the ultrasound toolbox is really a great thing. Ultrasound is no longer only a B mode of gray values. We have a lot of other opportunities in our fantastic toolbox. We can use B-flow, we can use Doppler, and there are now several Doppler methods around: color Doppler, angio-Doppler, pulsative Doppler, and also even tissue Doppler to estimate how the tissues move during physiology and pathophysiology. We can estimate fat of the liver with new elegant methods, as you can see on the right image here. Elastography has brought us further ahead regarding how to estimate fibrosis of the liver, and we can use strain imaging. We can also use shear wave imaging. And moreover, contrast-enhanced ultrasound, which is shown in the lower picture, can help us to gain more information about focal lesions of the liver, but not only the liver, also the bowels, the kidneys, the pancreas, and so forth. And then, as you also know, ultrasound-guided ablation techniques is very important. And we can now also even perform therapy using ultrasound, for instance, with the so-called sonoporation concept. So ultrasound takes you rapidly from vision to decision. Ultrasound, which you can use bedside, makes you do quick and rapid analysis of your patients to reach clinical decision-making very fast. Just like this lammergeier, a very interesting bird who has this very sharp vision. We hope that you also will develop this sharp vision, which make ultrasound a powerful tool in your hands. So let us now turn to the first speaker. Just let me also remind you about Q&A. We have a box you can write in questions, and we will mainly answer the questions after the talk. So please stay on for the whole event. So the first speaker is Dr. Andrea Boccatonda from Bologna. And as some of you may know, Bologna is a very famous place for ultrasound, and we have 2 speakers from Bologna today. So please, Dr. Andrea Boccatonda, show your slides.
Thank you, Professor Gilja, for your kind presentation. I will proceed to include the slide set. The title of my speech is The Approach to the Patient with Upper Abdominal Pain. And I will start from one question, this one. If you could do one quick and easy test to tell you what the likely cause of abdominal pain is, what would that be? And obviously the answer is ultrasound 1. And we will use this diagram, and in particular from this work published in 2020 in Internal Medicine. And it's interesting to observe that it's an experience, it's a Japanese experience from resident trainees. So it's very useful in our clinical practice. And it's interesting to observe that, first of all, when we face to a patient with upper abdominal pain, we should exclude peritoneal signs on physical examination. signs of shock and toxic appearance. And in this case, we should apply an initial resuscitation and apply eventually the so-called bedside ultrasound, in particular with algorithm aimed to evaluate signs of shock. We could remember the RUSH protocol or other type of these protocols. And the first thing to observe and exclude is the presence of a disease of the abdominal aorta, in particular on an aneurysmatic disease or on aortic dissection. And as shown in the slide, we remember that a normal diameter of the abdominal aorta is 120 millimeter. When we face to an abdominal aorta between 20 and 30 millimeter, we can speak about an aortic ectasia, and over 30 millimeter, this is considered as an aneurysm. In particular, we refer to this particular clinical situation of a ruptured abdominal aortic aneurysm that is characterized by a loss of the integrity of the aortic wall, in particular discontinuation of the intimal medial layer, and is almost suggestive the presence of this anechoic space behind the aneurysm that represents the presence of retroperitoneal hematoma or a peripheral evacuate collection due to the rupture. And usually the aneurysm is over 5 centimeters in diameter, and it is present usually free fluid in the abdomen. And this should be put together the clinical examination, so that sudden severe abdominal pain or a pain referred to the flank, signs of shock, and the physical examination suggestive for a pulsated abdominal mass. But these signs are present in fewer than 50% of cases. The second situation, a life-threatening situation, is obviously the aortic dissection, and in particular referring to the DeBakey or Stanford classification, the DeBakey 1 and the DeBakey 3 classification. There could be the extension to abdominal aorta, and the main findings, ultrasound findings, is the presence of the so-called intimal flap that can be visualized as this layer, a pericoic layer inside the lumen of the aorta. This is in our case, is quite clear in B mode, the presence of the flap inside the lumen of the aorta, and this is in transverse axis and longitudinal axis, the presence of the double lumen with arterial vascularization in both the lumen. Then we should exclude another life-threatening cause, such as the presence of a mesenteric ischemia, and some guidelines recommend to perform an abdominal CT, but in general, even ultrasound could evidence some signs suggest the presence of intraluminal thrombus in the venous in superior mesenteric vein or at the level of portal system. Then we should exclude the presence of a bowel obstruction, and in this case, the flowchart recommended the execution of the abdominal X-ray, but even the ultrasound can observe relevant signs, such as the presence of a diffuse dilatation of the small the intestinal loops over 2.5 and or 3 centimeters for an extension of at least 10 centimeters. The intraluminal content may vary according to the phase of the occlusion, and is typical the so-called to and fro peristaltic motion that can be observed in the video, such as a most relevant sign of bowel obstruction. When the obstruction involves the large bowel, there is a small difference in the diameter of reference, and in particular, we speak about a large bowel obstruction when there is a dilated segment over 4.5 centimeters. Then in our flowchart, we excluded these causes, these relevant life-threatening causes. We should investigate the presence of a different disease located in the right upper, then in epigastric, or in the left upper quadrant of the abdomen. In particular, we refer to disease related to the gallbladder. We see in this figure the scan, the principal scan, the subcostal scan, or the epigastric or the intercostal scans. And in particular, the most frequent disease is surely the presence of gallstone that we see as an oval-shaped formation with a precursor face and posterior cutis shadow. This formation can be mobile depending on the position of the patient, and it could be a gallstone or when there is a echogenic material of small dimension, we can refer as a biliary sludge. And it's important to remember that the gallstones are the main and principal cause of acute cholecystitis. And then the principal cause of right upper acute abdominal pain is the acute cholecystitis, and we observe the dilation of the organ. In particular, we speak about hydropic cholecystitis when there is a longitudinal diameter over 10 centimeter and a transverse diameter of 4 centimeter, a wall thickening over 3 millimeter, and a heterogeneous appearance of the walls. In most relevant cases, we should observe, as in the right figure and the figure on the right, the so-called double wall of stratified appearance that is an ultrasound sign of severe acute cholecystitis. And then the pathological process can extend over the wall of the gallbladder, thus leading to fluid collection, mural emphysema, and pericholecystic abscesses. Another relevant sign is the so-called Murphy's ultrasound Murphy sign that we observe as a sharp pain when we exert a pressure with the probe on the gallbladder point, and the Murphy sign has a positive predictive value of over 90% for acute cholecystitis. Another specific situation is the detection of air artifacts inside the wall of the gallbladder, and is a sign of specific complication of the disease called as emphysematous cholecystitis. Another example in which ultrasound is very useful, and in this case there is a clear acute cholecystitis, but there is an anechoic collection between the liver and the gallbladder, and the ultrasound is useful to insert a drain inside the collection and thus remove the fluid around the gallbladder and to resolve the abscess. About the guidelines, we remember that the 2020 World Society of Emergency Surgery guidelines recommend abdominal ultrasound as the first and preferred initial imaging method. And I reported the text in particular to observe that only 8 cross-sectional studies are involved in this recommendation, and only 2 studies reported a global accuracy that range from only from 70 to 79%. Moreover, the Tokyo guidelines in 2018, in which there are these TG18, TG13 criteria, and in particular to make a diagnosis of acute cholecystitis, there are 3 items, in particular: A, the local signs of inflammation, the Murphy signs; B, systemic signs of inflammation, fever, elevated CRP, and white blood cell count; and finally, at point C, the presence of imaging findings. So the appearance of an ultrasound, the imaging findings are necessary to make a definite diagnosis of acute cholecystitis. Then we deal about the biliary tract, and in particular, ultrasound is very useful to detect the presence of dilation of the biliary ducts, in particular intrahepatic or extrahepatic ducts. So ultrasound can lead us to a differential diagnosis between hepatic or prehepatic disease related to pain, and can be associated with a jaundice clinical picture, or a posthepatic dilation of the bile duct. In particular, when we have no dilation of the intrahepatic and extrahepatic bile ducts, we should refer to prehepatic or cellular level disease, such as several forms of hepatitis, acute hepatitis, or hematological disease. Or in these 3 situations, we could observe a dilation of the intrahepatic bile ducts, but the extrahepatic, the common bile duct, is collapsed and not dilated, So we suppose that obstruction should be at the hepatic hilum, so at the level of the hilum of the liver. And the main cause to exclude is surely the presence of either cholangiocarcinoma. And secondly, the presence of a primary sclerosing cholangitis, amyloidosis syndrome, and a gallbladder cancer. We report our case. It's clear that in this patient is present a heterogeneous mass at the hilum of the liver, 5.6 for 4.6 centimeter, with a clear dilation with hepatic bile ducts, and this case is confirmed by subsequent contrast enhanced ultrasound examination with a ring enhancement, a rapid washout, and this is a clinical picture and ultrasound picture of cholangiocarcinoma. The third situation is that in which all the bile ducts is dilated, and so the obstruction is out of the liver in the distal part of the common bile duct. And in this situation, we have two main causes. The one is the cholelocholithiasis, and the second one is a malignant one, the pancreatic cancer. In some situation, only the common bile duct can be dilated, and is referred to a gallstone that obstructs the lower and the common bile duct, and is an early clinical picture in which there is not enough time to induce a dilation of the intrahepatic bile ducts. So we can observe an example of cholelocholithiasis. In this case, there is a dilation of the common bile duct and a direct evaluation of a echogenic round formation inside the dilated common bile duct on the right. And then the neoplastic disease, in particular, we refer to cancer of the heft of the pancreas. And in this case, is our case, there is a clear dilation of the common bile duct and the intrahepatic bile duct. In this case, is just present a stent inside the common bile duct. The presence of a hypogenic and heterogeneous mass at the level of the head of the pancreas and the dilation of the gallbladder. And all these ultrasound signs could be resound as a corpuscular sign. That is a physical examination site, but could be observed even on ultrasound examination. Another case in which there is echogenic material inside the common bile duct that could be also large or a cancer or a neoplastic disease, we execute the contrast enhanced ultrasound, and this material is not perfused in all phases of the examination. So this is an obstruction induced by the accumulation of biliary sludge. Another relevant disease is the acute cholangitis, and on physical examination, we refer to the Charcot triad with fever, jaundice, and the right upper abdominal pain. And this clinical situation is linked to different bacterial infection induced by cholelocholithiasis, past surgical stenosis, neoplasm, acute pancreatitis. And even in this case, there are specific ultrasound signs that we observe, such as the dilation in hepatic bile ducts, the presence of the so-called hydrobilia that we observe as a hyperechogenic streaks with post-reverberation inside the bile ducts in the liver, and the thickening of the walls of the bile ducts. Ultrasound display a good sensitivity and specificity in detecting the dilation of the bile duct, but as a poor sensitivity in the evaluation of the cause of the obstruction. So a second-level imaging such as CT or MRCP or endoscopic ultrasound is often required. So this is the final diagram about the evaluation of the bile ducts, intrahepatic and extrahepatic, and the relevant. This evaluation can lead us to require different management and different consultation. In particular, the prehepatic and the hepatocellular disease require an internal medicine and the pathologist evaluation. Then the presence of dilatation of the intrahepatic or extrahepatic bile ducts often require a surgical or endoscopic consult. Finally, the pancreas is a main actor of this in this clinical situation. In particular, I remember the presence of heterogeneous endoblast mass, and is represented mainly by the ductal adenocarcinoma in 90% of cases that could be seen as a heterogeneous echoic solid mass, often at the level of the head of the pancreas. and the presence of pancreatitis, an acute pancreatitis that in early form can serve as an interstitial form with a focal and diffuse enlargement of the gland and a reduced echosensitivity due to the edema. And then in most severe forms, we can observe a form related to the acute necrotizing pancreatitis in which loss of tissue and fluid collection can be observed inside the pancreas and around the gland. So in conclusion, these are the main diseases and causes that we can observe on ultrasound related to hepatobiliary and pancreatic disease, but we should remember that in differential licheniasis, we should account for pulmonary, pleural, renal, metabolic, musculoskeletal disease. And this is my take-home messages. In particular, ultrasound is the first-line diagnostic tool in almost all the disease and clinical situation, but we should remember that in specific situation like a patient in shock with a suspicion of aortic aneurysm, rupture, or dissection, the CT scan is mandatory in early phase of the management of the patient. And we should remember the integrated imaging findings with clinically and laboratory findings, and the ultrasound can be repeated always, and every time we should need a checkup, a follow-up of the patient. Thank you for your kind attention.
Thank you very much, Andrea Boccatonda. That was an excellent lecture with a lot of practical hints and tips. I can see no questions in the Q&A. So to you who are attending this webinar, please use the Q&A box to address questions, and then the panel will answer after the 3 lectures. So then we move on to our next speaker. That is Professor Carla Serra from Bologna also. And she is a well-known worldwide expert in ultrasound. She has published quite a lot on abdominal ultrasound and contrast agents. So please, Carla. Please share your screen.
Okay. You can see my screen now?
No, not yet.
Not yet?
Now, there we are. We saw it in 2 seconds. Yes, we can see it. And if you put it on that one, yes.
Perfect. Good afternoon to everybody. It's a pleasure for me to take part of this EFIM Academy Congress meeting concerning abdominal ultrasound. So acute hepatitis disease, you know, is a sudden liver dysfunction that may lead to acute liver failure. And we have a lot of common causes like viral hepatitis, drug-induced hepatotoxicity, ischemia, biliary obstruction, Budd-Chiari, fatty liver, abscesses. And the role of ultrasound is so important for acute hepatitis because you know that ultrasound is non-invasive, real-time, repeatable, and bedside available. So usually, ultrasound is the first-line modality for acute liver evaluation, and it can differentiate between hepatocellular versus biliary causes. And then we can also use ultrasound to guide further imaging management. And so this is a real important imaging technique in this tool, in this context. The objectives of ultrasound are so many. First of all, we can assess the size of the liver, the echo texture, and vascularity. And it's so important to exclude biliary obstruction or vascular occlusion, but also to identify focal lesions. Finally, ultrasound can guide you for interventional option like biopsy or in case of abscess to guide drainage. So when you have a patient with a suspicion of acute hepatitis, ultrasound, first of all, must differentiate between biliary and hepatocellular disease. And so this is the reason why immediately we use ultrasound to evaluate biliary tract, because if like in this case, you have dilated ducts, intrahepatic, also you can see biliary stones, and you have this typical image of the so-called parallel channel sign, you can do the diagnosis. And you know that ultrasound has high sensitivity and high specificity to distinguish hepatitis for extrahepatic occlusion. And you can see clear case of a huge dilatation of the biliary duct. So now we move to what ultrasound can give you in terms of typical ultrasonographic findings. You look at different structure of the liver, the parenchyma, the morphology of the liver, but also gallbladder, bile ducts, lymph node, and spleen. And the sonographic appearance are different. It depends on the gravity, the importance of the acute hepatitis, and all these kind of findings are due to inflammation, edema, congestive disease, inflammatory reaction. So we can evaluation this structure one after one. This is the typical case of acute hepatitis, and in this case you can see the echogenicity of the liver that is in part decreased in some portion of the liver, and in other portion is increased. And this inhomogeneity is usually due inflammation and edema. And this is a typical case of acute hepatitis. Another important sign is the so-called starry sky appearance. You can see here echogenic portal triad that are so well visualized in the hypoechoic parenchyma. And you can see also in this video what is the typical starry sky appearance. You can see the typical appearance. And another sign of acute hepatitis is the periportal hyperechogenicity that is well visualized if you use a high frequency probe. You can see in this case the hyperechogenicity, and this is caused by interstitial edema. Concerning the liver morphology, usually you can see a hepatomegaly. We have here two cases. One, you can see that the liver is slight, mild, enlarged, but in this case you have a huge liver. You can see the longitudinal right lobe size that is more than 19 centimeters. And also this appearance is due to congestive or inflammatory swelling. Another important evaluation during acute hepatitis is to evaluate the gallbladder. Because usually the gallbladder show a thickness of the wall, usually more than 3 millimeters, and this is a sign that occurs in 70–80% of acute hepatitis. And often this is associated with a pericholecystic edema, the so-called reactive wall. So you can see here the image and the typical sign. Sometimes you have the thickness of the wall and also sludge inside the gallbladder. Another possibility is the so-called ghost gallbladder sign. In this case, you can see that the gallbladder is collapsed, and this usually is due to a severe inflammation. And this is another pattern that you can see in case of gallbladder pattern. Concerning the spleen, usually due to the systemic inflammatory response, you have only a mild splenomegaly, usually not huge. If it is acute in the onset. In case of acute on chronic hepatic disease, you can see a larger spleen, but in case of only acute hepatic disease, the spleen is not so enlarged. And also you can look at the ileum to evaluate eventually the presence of lymph nodes. And you can see here one lymph node, two lymph nodes that is due to the inflammation. And this is usually a normal finding during the examination. Now we move to Doppler evaluation, because we have also changes in Doppler flow in the evaluation of both the portal and suprahepatic and the hepatic artery. And so we need to evaluate all the vessels to evaluate what the hepatic inflammation cause in the flow. Concerning the portal vein, we can have a normal or a slightly decreased velocity. This is a case of normal flow. In case of hepatic vein, we can have a compression of the vessel due to inflammation or the edema. And in some cases, we can have also a flattened in case of severe congestion. We can see here a case of reduce of the normal reduction of the normal triphasic flow of the suprahepatic vein. And finally, we have also some finding concerning the hepatic artery, and we can see an increase of the flow velocity and a decreased resistive index. We can see here a RI about of 0.72 due to dilatation due to the inflammation. Now we move to a prognostic role of the ultrasound, because sometimes the evaluation of the gallbladder and the improvement of the wall thickness might correlate with a worse outcomes in case of hepatitis A virus. And also normalization usually parallels biochemical recovery, while a persistent flow abnormality suggests chronicity or vascular compromise. So it is important to use ultrasound not only at the beginning of the evaluation of your patients, but also during the follow-up. What about elastosonography? Well, in acute hepatitis, due to the elevation of transaminase, is not important to evaluate the liver with the elastosonography, because you usually have high value, but high value doesn't mean that the liver is fibrotic, because the edema, the congestion of the liver give you an elevation of the value of the elastosonography. So the stiffness of the liver increased, but is not due real to fibrosis, but to congestion. And it's important also to use ultrasound, as I mentioned before at the beginning, to perform liver biopsy that in many cases can help you to do the final diagnosis. And what about another important ultrasound examination, that is contrast enhanced ultrasound examination? We have not so many information with the contrast ultrasound, because sometimes the technique shows a hypervascularity with sometime washout, but the only role is to evaluate the presence of focal liver lesion. To be honest, no more information about liver parenchyma. Another important role of ultrasound is at the end to do the differential diagnosis concerning other important cause of elevation of the hepatic laboratory test, and in particular acute hepatitis might be differentiated not only with extrahepatic cholestasis, but also with hepatic steatosis and hepatic congestion. And you can see that sometimes the echogenicity is different, in particular in hepatic steatosis, in which we have the typical bright liver. But in this case, we have the typical findable gallbladder, and in case of hepatic congestion, we have an important sign that is the dilatation of the hepatic and the inferior vena cava veins. And so it's important to evaluate both the B-mode finding and the vascular finding, because you can see that we can differentiate different causes of alteration of the hepatic laboratory test. So I think that for acute hepatic disease, ultrasound is so important, because you can do a rapid bedside assessment in all the cases of acute jaundice or hepatic failure. And so you can immediately differentiate between hepatocellular and obstructive or vascular causes, but the technique is so important to monitor disease evolution and also to guide biopsy. To be honest, the technique has some limitation, because some findings that we have looked at are not specific. So it is important to correlate ultrasound findings with the laboratory and the clinical setting. And the etiology is not in many cases determined by ultrasound, and the important things is to integrate ultrasound with the biochemical test, clinical history, and at the end to use ultrasound for the follow-up of the patient. You can see more information in the EFIM WFUM guidelines, also in the guidelines. And thank you for your attention.
Thank you very much, Professor Carla Serra. That was an excellent talk with lots of clinical valuable information to all the people doing ultrasound. So please stay tuned. We will look at the Q&A to answer questions later. And then we have our last speaker today. That is Dr. Claudio Marone, also from Italy. So now we're going south in Italy to Naples. Hopefully, we will have no internet trouble, as Naples earlier today were crashing its internet in totally chaos. But hopefully now Claudio is back online. So please, Claudio, show us about the urinary system and how you can use POCUS in the ovulation, please.
Thank you all to all the participants to be here, and thank you to the organizer to let me be here with such important speakers. I'm sorry for the internet problem, but it was not my fault. I'm going to talk about the role of POCUS in the evaluation of the urinary system, and we know how common urinary pathology are in the internal medicine departments. So we are going to see almost every day. What I always say, being practical, so use ultrasound with an internal medicine mindset, with an internal medicine spirit. So, of course, we are going to evaluate the evaluation of the kidneys, the bladder, and the ureters. But we have to say that other technique like Euro-MRI is the best technique for the study of the parenchyma and the excretory tract. The CT scan is the best technique for the study of the obstetric component, and the ultrasound, the POCUS, is the first level investigation for the parenchyma evaluation and the possible dilatation of the excretory tract. We use a 2.5 megahertz transducer in BMUD, the convex probe with a patient in a supine or the cubitus position, but mostly in the cubitus position, and we have a longitudinal and transverse ultrasound approach. And it's important to use both to have an idea of the organs complete. What we are going to see, just say from the kidney, we are going to look at the parenchymal echogenicity that can be evaluated in relation to the liver and the spleen. Pay attention with the cirrhotic patients, and we have a grade from 0 to 3. And dimension that normally it's from 90 to 125 millimeter in longitudinal diameter. And the cortical medullary thickness. So in the chronic pathology, we are going to see a reduction of thickness and increase of echogenicity. In the acute pathology, we have increase in thickness. How it happens, how we see a normal kidney, we see the layer of a perinephric fat surround the cortex. Then we see the cortex, then appear more echogenic than medulla, while appearing hypo or isoechoic, compared, of course, I just said before, to the liver and the spleen. We see the pyramids, the tips of the pyramids that are oriented toward the renal sinus and form the papilla that excrete urine in the minor calyces, which fuse to form the major calyces, and then the renal pelvis. The renal sinus appears hyperechoic on ultrasound. In the chronic disease, we see kidney smaller, of course, and just length of less than 9 centimeters is really, really suspicious. We see increasing of cortical echogenicity and a reduction of cortical thickness. That should be measured from the base of the pyramids to the capsule. And in the acute disease, how I told before, we have enlarged kidney and hypoechoic structure. Just let me say something about the color Doppler ultrasound. It's important to know the renal resistive index, that it's calculated as a ratio of peak systolic velocity to the end systolic velocity in the renal arteries. And is really important because a RRI greater than 0.7 is a huge marker of renal parenchymal damage. I mean, the most important thing, I mean, one of the most frequent things that we are going to see in our department is the obstructive disease. That it's a urinary tract obstruction is an obstacle to the urine flow that, if not corrected, and of course if it's bilateral, can cause a progressive deterioration of the kidney function. And about this, the focus is really sensitive and has a lot of specificity. But we are going to look. I mean, we are going to look for the hydronephrosis. That it's we're going to look at the obstruction, and we're going to see the hydronephrosis. That it's a lot of anechoic urine. And we have like different grade of hydronephrosis, mild, moderate, and severe, or 1, 2, 3, 4. I mean, we have different classification. But I mean, just you have an experience, and you can see from your clinic. I mean, we have different causes of urinary tract obstruction. We can have congenital obstruction and acquired. I mean, congenital are more rare, and what we are looking for is generally the acquired one. Just the urotherocele that sometimes we can see between congenital causes. We can see ureteral prolapse into the bladder right in the right figure. And let's talk about the urinary tract calculosis. We on right, we are going to see a kidney calculosis, like hyperechoic image with a posterior shadow cone. Let's say that the ultrasound has a sensitivity of 16% for stone smaller than 7 millimeter and 75 for stone bigger than 7 millimeters. So we are not always seeing the stones, not always. So, like I told in the beginning, we are also using the clinic. So clinic together with POCUS. And let's say if we have if we don't have the direct visualization of the stone, but we see hydronephrosis, then we can support strongly the renal colic. The bladder is the second organ we are going to see. And the examination is performed with the transverse suprapubic scan. We have different formulae to look at to measure the volume. I show here the most common formula. Here I show you a very common alteration, that it's the stress bladder, that it's caused from a chronic obstruction like prostatic hypertrophy, and associated with the irregularity of the margins. You see, another really common pathology that we are going to see is the urinary retention. I mean, the urinary retention, it can happen also when we have a patient with catheter. I mean, if we have clothes inside, if we have sediments, if we have patients that have this catheter from long time. So we have all these imaging anechoic with the urine, and all the walls of the bladder stressed. And Another pathology that can cause obstruction and we can see frequently, especially in the elderly patients, it's the bladder cancer. Here we see a neoplasm of the bladder floor just up at the trigon level, that the site of the emergence of the ureters. The bladder tumors present as or vegetating, infiltrating, or mix, and sometimes we can have a subversion of the bladder wall. The prostate, we always have to study together with the bladder, and it presents like a chestnut shaped. And the volume is the most important thing we are going to see. And increased volume, of course, it's the prostatic hypertrophy. Normal, the volume less than 30. The prostate cancer, also frequent, is or hypoechoic nodular formation that can lead to echostructal destruction of the gland. About the urinary tract infection, we have to say that we are not going to see directly some signs of the infection, but we are going to look for what is inside. I mean, for the underlying obstructive uropathy and for the complication like pyonephrosis, abscess, emphysematous pyelonephritis. So this is an evidence of emphysematous pyelonephritis that appears like a high amplitude echogenic focus associated with the distal dirty shadowing or low level echoes and reverberation caused, of course, by the near total sound reflection at the tissue-air interface. The abscess, I mean, is inhomogeneous, hypoechogenic, and it's similar to a solid structure. It's difficult often to characterize between it and a solid neoformation, and it's important using the ultrasound contrast medium. But about this we are going to talk maybe it's really long discussion, so maybe in another webinar. The cysts are maybe I think it's the most common pathology that we are going to see when we start to use the ultrasound, because they are really common. We found in almost 50% of the general population, and they appear like circular, ovoid shaped, anechoic structure with posterior acoustic enhancement. Sometimes, especially in the beginning, it's hard to distinguish with hydronephrosis. But while hydronephrosis progresses from the renal pelvis to the major and minor calyces and then to the cortex, cysts are cortical or parapelvic. And we can also use the technique of key. I mean, you can turn your convex, and of course the cysts are not confluent, comparing, of course, from hydronephrosis. This is the famous Bosniak classification. Just a few things about maybe the two neoplasm of kidney more frequent here. The angiomyolipoma on the left, that it's a benign tumor really frequent with a capsule and grows slowly, appears solitary as a hyperechoic nodule, and it has clear regular margin. And it generally lacks a Doppler signature on the right, adenocarcinoma, that appears as heterogeneous nodular lesion with intranodular microcyst and thin hypoechoic halo. I want to conclude with saying this, that in the renal failure in generally, ultrasound using, of course, the internal medicine mindset can help us a lot to distinguish between the pre-renal, renal, and post-renal failure. I mean, for example, renal parenchyma, renal, we are going to see how I show you the parenchymal alteration. If we think about pre-renal, like for example, from a dilatation, we are going to use focus looking for the cava, the vena cava that can be really small. We are going to use focus for giving a look to the heart. And post-renal, I told in this presentation a lot, we are going to see the obstruction. I want to thank you. I hope to be clear. It was clear. Thank you for your attention.
Thank you very much, Claudio Marone. That was a very nice lecture. And we have some questions for you in the Q&A panel. I will read them loud and you can answer afterwards. So first question is, what is the relationship between renal cortex thickness and glomerular filtration rate in chronic kidney disease? Can you add some comments to that, please?
I didn't the thickness. Sorry?
What is the relationship between renal cortex thickness and glomerular filtration rate in chronic liver disease?
I mean, we have the in the glomerulonephritis. I mean, we can also don't look. I mean, sometimes we cannot see sometimes the alteration. So about glomerulonephritis, the clinic is the best. But what can help us is the RRA. That I told during the presentation, that it's highest and then can be helpful for us.
Yeah, let me please add to that. There is a good relationship between renal cortical thickness and glomerular filtration rate. If you have a very small, below 10 millimeter thickness, that would indicate chronic liver disease or failure. So if you have a broad cortex and above 1 centimeter, that's a healthy sign of enough glomerular filtration rate. And there is another question for you, Dr. Marone. Yeah. Is there a case in chronic liver disease where the kidney enlarges?
Sorry?
Is there cases in chronic liver disease, like kidney disease, where the kidney enlarges, becoming larger, bigger?
Yeah, this is, I mean, in this, actually, I read from the book about this. I saw just maybe once in the diabetic patient. So in the beginning of this, in this case, there's I mean, the kidney is enlarged. So even if it's a chronic disease, in the beginning, that's an allergic kidney in the first phase. But I saw just one. So maybe if someone of you has more experience about it, can help. Add something.
One obvious answer is, of course, polycystic kidney disease. They are getting very large, and that's a chronic disease. But that's also a very easy task to diagnose on ultrasound. You will see a kidney full of cysts all over the place. Okay. And then we have a third question for you. Can the ultrasound help in the diagnosis of pyelonephritis? What do you think, Marone?
Pyelonephritis. Yes. 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 They can help us. I mean, I told you during the presentation.
Yes, we can add something about contrast ultrasound. because to be honest, sometimes BMOD evaluation of the kidney in case of pyelonephritis, when we have not complications, can be normal. And sometimes also small portion of inflamed kidney cannot be evaluated with BMOD. Some more information can be added with the use of contrast ultrasound. If Andrea want to add some more information about the use of contrast ultrasound for this tool, please, Andrea, add something.
This is one of the most relevant and actually application of the contrast ultrasound in internal medicine and emergency medicine, and in particular on BMOD ultrasound we can observe in most severe cases cortical areas of hyperechoic or even hyperechoic modifications, but the real game changer is surely the contrast ultrasound, in which we can detect, in particular, hypoperfused areas, especially in the portal and late phase of the exam. And is in the first phase of the contrast ultrasound, the area can be perfectly perfused, and the hypoperfusion can be observed only later. So I suggest to perform the examination on the 2 minutes, but extend over even 4 minutes to detect this area.
Okay, thank you. And then we have a question for you, Carla.
Yeah.
Do you have any information about the learning curve for hepatobiliary ultrasound? How many cases do you need in your log book for attaining competency? Do you have any good advice there?
Well, I think that 1 month of experience in a pathological department where you can see almost 10 cases a day can be enough to be competent of all the huge application of ultrasound for gastrointestinal purpose. In particular, I think that for liver, for biliary, because the question is not only evaluate the liver for diffuse disease, but we have an important objective to evaluate liver focal lesions, and this is an important application in this case, and we need to have a lot of experience to differentiate the different lesions, benign and malignant. So I think that almost 1 month in an important department is the perfect time to acquire this experience.
Thank you, Carla. Let me also add that a few years ago, the European Ultrasound Federation, EFSUM, gave out some practical recommendations regarding how to develop expertise. And they stated that around 300 examination is something you need to achieve in order to be totally independent as an ultrasound examiner. But that's a rough guide, of course, but give some idea.
10 cases for 30 days.
Yes.
Perfect.
Perfect. You do the calculations, Carla. Very good. So we have also, do we have any more questions? It's one about the presentations. Maybe the lecturers are willing to share their PDF files for the attendance. I hope you can be, that can be available. There seem to be no more questions, but let me also point that 3 questions are already answered in writing, so you can log into that. So finally, I would just like to thank all of you, particularly the lecturers, for giving such an excellent lectures And also thanks to all the participants who have been joining us now. And remember, ultrasound is a fantastic tool, and you have a fantastic toolbox available at the tip of your fingers to do the best of your patient. Thank you very much and have a nice evening. Bye-bye.
Bye-bye. Thank you.
Thank you. Bye.
Bye-bye.